Hi everyone, my name is Nashaka Goni and I'm honored to present my Doctor of Nursing Practice project titled Reducing CAUTI, or Catheter-Associated Urinary Tract Infection, Rates by Implementing a Foley Catheter Champion Role in the Neuro ICU. This project was completed as part of my DNP program at Maryville University's Catherine Macaulay School of Nursing. I want to briefly recognize my committee. My chair is Dr. Maria Snell. My second reader from the course Nurse 705 is Dr. Douglas Bartelt. And my community member is Monique Cruz, who was the nurse educator of the Neuro ICU. The aim of this project was to reduce Foley catheter indwelling duration in the Neuro ICU by implementing a catheter champion role over an 8-week period. The PCAUT question guiding this work asked whether in an adult neuro ICU, patients with an indwelling Foley catheter would implementing a catheter champion role compared to our pre-implementation practice would reduce average Foley catheter indwelling time over 8 weeks. The local picture made this urgent. Before implementation, our neuro ICU had general catheter care protocols in place, but no designated professional responsible for systematically evaluating catheter necessity each shift. The pre-intervention baseline showed a median Foley catheter duration of 5 days with a mean of nearly 7 days, and individuals' cases stretching to 37 days. Unit leadership had already flagged catheter-associated urinary tract infections, also known as CAUTIs, as priority concern before this project began. That matters in a neuro ICU specifically. Our patients have altered mental status, limited mobility, and often require strict intake and output monitoring. Clinical factors that push catheter utilization up and keep catheters in longer than they need to be. The stakeholders in fixing this range from the bedside of nurse and charge nurse to the nurse manager, intensivist, and infection prevention team. It matters for now for 3 reasons. First, the human cost. CAUTIs cause an estimated 13,000 deaths annually and account for $1.7 billion in direct healthcare costs. Second, every additional catheter day increases CAUTI risk by 3 to 7%, meaning duration itself is a modifiable target. Third, financial pressure has aligned with clinical missions. Since 2008, Centers for Medicare and Medicaid Services, CMS, have not reimbursed hospitals for CAUTI-related costs, and value-based purchasing ties quality metrics directly to reimbursement. Between 65 and 70% of CAUTIs are preventable. Before designing the intervention, I did an extensive literature review, and I want to highlight the key findings that shaped this work. First, the evidence is clear that prolonged catheterization is the primary modifiable risk factor for CAUTIs. I want to reemphasize Dasinska and their colleagues documented that each additional catheter day increases infection risk by 3 to 7%, a dose-response relationship that puts the burden squarely on how long the catheter stays in. Second, the nurse-driven removal protocols work. A systematic review by Durant showed that when nurses are empowered to remove catheters according to established criteria, urinary catheter utilization drops over 50%. Yatim and their colleagues validated the Houdini framework specifically, achieving 89% nurse compliance and demonstrated that the mnemonic raised nursing awareness of routine catheter evaluation. Third, champion-led implementation delivers sustained results. Schizler and their colleagues implemented a nurse-driven protocol in a pediatric ICU and saw the CAUTI rates drop from 4.8 to 0.8 per 1,000 device days. Gupta and colleagues sustained 280 CAUTI-free days in an adult cardiac ICU, and Al-Sayagi and their colleagues demonstrated that structured oversight, exactly what a champion role provides, improves compliance with prevention guidelines. Van Dyker and their colleagues synthesized much of this work and concluded that between 65 and 70% of CAUTIs are preventable through evidence-based interventions like these. That evidence-based spanning adults, pediatric, cardiac, and rehabilitation settings is what convinced me the catheter champion model would translate to the neuro ICU. I chose the PDSA, or Plan, Do, Study, Act, as my theoretical framework to guide this project. PDSA fits quality improvement work like this because it's iterative and rapid cycle, which is designed for exactly the kind of 8-week implementation window I had. In the plan phase, I defined the practice problem, formed the interdisciplinary team, secured stakeholder support from the unit leadership, and designed the catheter champion role. During the do phase, we implemented the role on each shift, educated every registered nurse and unit leader on the Houdini protocol and the hospital's urinary retention protocol, and began daily catheter audits. The study phase is where the analysis happens, comparing pre- and post-implementation catheter durations using descriptive and inferential statistics. And finally, the act phase, which is really where we are now, is about deciding whether to sustain, refine, or expand this intervention based on what the data showed. PDSA also shaped how I built the intervention. It gave me a repeatable rhythm, plan a change, run it, study what happened, then act, that let me adjust as I went. If the audits weren't happening consistently, PDSA gave me a framework for identifying the gap and responding to it, rather than waiting until the end to notice. This project used a quantitative quality improvement design, specifically a retrospective chart review comparing Foley catheter indwelling duration during 2 8-week periods. The pre-implementation period ran from March 7th through May 30th, 2025. The post-implementation period ran from June 1st through August 5th, 2025. I chose this design for 4 reasons. First, it directly answers the practice question using objective timestamp data that already lives in the electronic health record. Second, it imposes zero burden on the patient, no direct contact, no interviews, no additional procedures. Third, it was feasible within my 8-week practicum window. And fourth, it aligns with how nearly every published CAUTI quality improvement study has approached this kind of evaluation. The intervention itself was the catheter champion role, structured around the Houdini protocol and the urinary retention hospital protocol shown on the right side of the slide. Houdini is a mnemonic that provides nurses with a structured, evidence-based framework for determining when a Foley catheter remains clinically indicated. The acceptable indications are hematuria, that is gross, obstruction of urinary tract, urological surgery, decubitus ulcer or immobility with incontinence, strict input and output monitoring, nursing end-of-life care, and immobility from acute physical constraints. And as I said, I added urinary retention outside the Houdini protocol since we did have a hospital policy in place for urinary retention. If a patient doesn't meet one of these criteria, the catheter comes out. The final sample was 228 patient records, 130 from the pre-intervention period and 98 from the post-intervention period. This exceeded the range I had projected in my original IRB proposal, which was between 80 and 130 records total. Having a larger than anticipated sample gave the analysis more statistical power and strengthened the conclusions. Inclusion criteria were straightforward. Patients had to be at least 18 years old, admitted to the Neuro ICU during one of the study windows, have an indwelling Foley catheter placed during their stay, and have complete documentation of catheter insertion and removal dates. Records were excluded if the patient was under 18, didn't have a Foley catheter, had incomplete data documentation, or had unknown insertion date. I intentionally did not collect demographic variables like age, sex, or diagnosis. The Neuro ICU population is diverse and broadly reflective of our local community, and the primary outcome of interest being catheter indwelling duration, which did not require demographic stratification. That kept the design tight and reduced the risk to patient privacy. Moving on to data analysis, the analysis compared 2 groups on one continuous outcome. The independent variable was group assignment, or pre versus post intervention. The dependent variable was the Foley catheter indwelling duration in days. Now, I originally expected to run an independent samples t-test, which would be the standard tools for comparing 2 groups on a continuous variable. But when I ran the descriptive statistics, both distributions were heavily skewed. The pre-intervention skewness was 2.55 and the post-intervention skewness was 4.68. For context, a skewness above 1 signals a distribution that's meaningfully non-normal. These distributions were nowhere near normal. Both groups show the same pattern. Most patients had shorter catheter durations with a long tail of extended cases stretching out to 30 or 37 days. That shape makes a parametric t-test inappropriate because the t-test assumes normally distributed data. So with the help of Dr. Mark Paul, the statistician here at Maryville University, I used the Mann-Whitney U-test instead. The Mann-Whitney U-test is a non-parametric test that ranks the values rather than comparing raw means. And it's specifically designed for comparing two independent groups when the assumption of normality is violated. It's the right tool for this data shape. I'll dive into the Mann-Whitney results you see here in 2 slides. Here are some more important results, the descriptive statistics. In the pre-intervention period with 130 patients, the median catheter duration was 5 days. The mean was 6.88 days, with a standard deviation of 6.90 and a range from 0 to 37 days. In the post-intervention period with 98 patients, the median catheter duration dropped to 2.5 days. The mean fell to 2.85 days, with a standard deviation of 4.94 and a range from 0 to 30 days. Translated into percentages, that's a 50% reduction in median catheter days and a 59% reduction in mean catheter days. Every one of those days matters because the literature tells us each catheter day carries a 3 to 7% additional CAUTI risk. But there's a third finding on the slide that I want to flag because it's just as important as the reduction in duration itself. Now, when looking at the standard deviation, it dropped from 6.90 to 4.94. That reduction in variability tells us the catheter champion rule didn't just make catheter management faster on average, it made it more consistent. Across shifts, across nurses, across patient types, the practice became more uniform. To me, that suggests we didn't just change behavior on the days the champion was rounding, we shifted the culture of catheter stewardship on the unit. Descriptive statistics tell us what happened. Inferential statistics tell us whether it happened by chance. So to continue, let me tell you what we learned from the Mann-Whitney U-test. The Mann-Whitney U-test ranks every catheter duration from shortest to longest and then compares how those ranks are distributed between the two groups. The U statistics of 2,515.50 reflects that the comparison, the lower the U relative to the sample size, the greater the separation between groups. The z-score of negative 7.893 converts that U into a standardized value showing how many standard deviations the result sits from, what we'd expect if there were no differences. Anything beyond about positive or negative 1.96 is significant. So negative 7.893 is far into the tail. Together they produce a p-value of less than 0.001, meaning the probability this reduction in Foley days happened by chance is essentially none. Therefore, we can confidently conclude the catheter champion role drove a real statistically significant decrease. More simply, the probability that this difference occurred by random chance is essentially 0. There is a real statistically detectable difference in catheter indwelling duration between the pre- and post-intervention groups. But statistical significance alone isn't enough, especially with a sample of 228, where even small effects can register as significant. So I calculated the effect size using the rank by serial correlation, which is R equals Z divided by square root of N. That came out to R equaling negative 0.52. By Cohen's 1988 conventions, an absolute effect of 0.5 or greater is a large effect. So this change is not only statistically detectable, but it's clinically meaningful. In a clinical context where every day of reduced catheter time lowers CAUTI risk by 3 to 7%, a large effect size means real patient benefits. Next up is limitations. I want to be transparent about the limitations of this project because interpreting the results honestly matters more than presenting them favorably. First, this was a single-site project conducted in one neuro ICU at one facility. That limits how widely we can generalize these findings to other units, patient populations, or healthcare organizations. Second, the 8-week implementation and data collection windows may not capture the long-term sustainability of the intervention. What happens at 12 weeks? At 6 months? Does adherence hold when the novelty wears off? So then the third point is that this was a QI project, quality improvement project, with a retrospective pre-post design. There was no concurrent control group. External variables like changes in patient acuity, staffing patterns, seasonal trends may have contributed to what we observed. Fourth, the original protocols have specified per shift audits by the champion. In practice, audits happen most days, but not every single shift, largely due to staffing constraints in a busy ICU. That likely introduced some noise into the intervention. And finally, data collection was limited to active charts rather than comprehensive retrospective query of every neuro ICU admission. That could introduce selection bias if patients with unusually short or long catheter durations were disproportionately excluded. None of these limitations undermine findings of a large statistically significant reduction, but each of them tempers how far we can push the conclusions. So let's return to the question that started this discussion. The guiding question was, in a neuro ICU setting, how does implementing a catheter champion role affect the average Foley catheter indwelling time compared to pre-implementation practices over an 8-week period? The answer is that catheter champion role significantly reduced the average Foley catheter indwelling time. Median duration fell by 50%, mean duration by 59%, and the effect size was large. The intervention worked. 3 interpretations are worth pulling out. First, these findings are consistent with evidence base. Schizler and colleagues reported a 28% reduction in catheter device days in a pediatric ICU using a similar nurse-driven model. Gupta and colleagues achieved a 280 CAUTI-free day in an adult cardiac ICU. Our results sit comfortably within that body of literature and add a neuro ICU data point that hadn't been well represented before. Second, the reduction in variability. The drop in standard deviation from 6.9 to 4.94 suggests this wasn't just a behavioral change on the days the champion was rounding, it was a shift in unit culture. Catheter management became more consistent across staff and shifts, which is the hallmark of an intervention that's actually taken hold. And third, this is a nurse-led, low-cost model. The intervention requires no new technology, no additional staffing, no expansive resources. It relied on education, role designation, and standardized decision framework. That makes it replicable, which brings us to the practice implications. The implications of this project reach in 4 directions. For patients, fewer catheter days directly reduce CAUTI exposure. They also improve mobility, comfort, dignity, and shorten length of stay. These are outcomes that matter enormously to a vulnerable neuro ICU population. For nursing, this project reinforces something we sometimes lose sight of. Nurses, when equipped with evidence, structure, and authority, can lead system-level change. The catheter champion role gave RNs education, standardized decision criteria, and the confidence to initiate conversations with providers about removal. That's the kind of nursing autonomy that improves both outcomes and professional practice. For the healthcare system, this is a low-cost, high-yield intervention. Individual CAUTI cases cost roughly $2,400 each and extend length of stay by 2 to 4 days per patient. A 50% reduction in catheter days translates to real savings plus better performance on CMS value-based purchasing metrics and quality reporting. And finally, for equity, CAUTIs disproportionately affect vulnerable populations such as critically ill, the elderly, patients with limited mobility, or altered mental consciousness. By applying Houdini criteria in the hospital's policy on urinary retention consistently to every catheterized patient, the champion model helps ensure equitable, evidence-based care regardless of who the patient is or which shift they happen to be on. To summarize what this project accomplished, we achieved a statistically and clinically significant reduction in Foley catheter indwelling time, a 50% drop in the median, and a 59% drop in the mean. The effect size was large, variability decreased, indicating more consistent practice unit-wide, and we established a scalable, low-cost nurse-led model of catheter stewardship in the neuro ICU. Looking forward, my recommendations are to formalize the champion role in unit policy and orientation, to extend evaluation beyond 8 weeks and measure CAUTI incidence indirectly with a larger sample, and to scale a model to other ICUs and med-surges within the facility. Long-term, embedding catheter necessity alerts in the EHR could complement the champion's work and further standardize the process. If I were to do this project again, I would build in dedicated audit time from the start rather than relying on champions to fit rounds into an already full shift. That was the single biggest implementation challenge, and it's fixable. On a personal note, the DNP program has fundamentally changed how I see nursing. I started this program as a bedside nurse. I'm leaving as someone who can lead system level change, someone who can read the evidence, design an intervention, work with stakeholders, analyze data with statistical rigor, and translate findings into action. I've learned to be humble about what the evidence can tell us and confident about what nurses can accomplish when they're given the tools and the authority to lead. That transformation is what the DNP is for, and I'm grateful to have gone through it. Here are my references that I used throughout my presentation. And here are the remainder of my references. That is all I have. Thank you for watching.